Hello everybody. Today we are going to discuss about the ST elevation MI, the complications. So ventricular arrhythmias are common following the onset of the STEMI, but the impact on the outcome depends upon the timing of the onset. Previously, it had been thought that ventricular tachycardia occurring early after presentation did not influence the long-term outcome if it was rapidly terminated, whereas the ventricular tachycardia occurring beyond 48 hours had ominous implications. However, in more recent analysis of 5,745 patients with STEMI from the assessment of the pexilizumab in acute myocardial infarction trial, 5.7% developed VT or VF, which was associated with worse overall 90-day mortality. Of those who develop ventricular arrhythmia, 64% occurring before and the end of index cardiac catheterization, and 90% occurred within the first 48 hours of the STEMI presentation. Those patients whose ventricular arrhythmia occurred after index catheterization, but less than 48 hours after presentation, had increased incidence of mortality at 90 days. Ventricular fibrillation is the primary mechanism of the arrhythmic sudden death. In patients with acute MI, most episodes of ventricular fibrillation occur early after infarction as sustained VT, and late ventricular fibrillation occur frequently in patients with severe LV dysfunction or heart failure and is poor prognostic marker. Patient with VF and sustained VT associated with symptoms or hemodynamic compromise should be cardioverted emergently. Underlying metabolic and electrolyte abnormalities must be corrected, and ongoing ischemia must be addressed. We aim to maintain serum sodium level between 3.5 to 4.5 and serum magnesium of 2 milliequivalent or more. Intravenous amiodarone is particularly effective antiarrhythmic agent in patients with acute MI because it lowers the heart rate and does not have significant proarrhythmic properties. Lidocaine remains the effective alternative if amiodarone is not tolerated and is unsuccessful in controlling arrhythmia. The use of class 1C antiarrhythmic agents such as plecanide and the propafenone is contraindicated given the paradoxical proarrhythmic effect and excess mortality seen in CAST trial. Prophylactic use of antiarrhythmic agent other than beta blocker is not indicated. Given the absence of benefit in the randomized control trial, routine restratification to guide ICD placement early after STEMI is not recommended. However, reassessment of LV function 40 days or longer after STEMI can guide consideration of ICD for primary prevention of sudden death. Variable cardiac defibrillators can be considered in the immediate post-MI period in patients with LV dysfunction. However, the largest trial examining this issue, the WASTE, did not demonstrate a significant reduction in arrhythmic death. Bradyarrhythmia. The usual cause of bradyarrhythmia is increased vagal tone, ischemia, and infarction of the conduction tissue. Sinus bradycardia is typically caused by irritation of the cardiac vagal receptor, which are located most prominently in the inferior part of the left ventricle. Thus, these arrhythmias usually seen with inferior MI if heart rate is extremely low. Morbid second degree AV block is also common among patients with inferior wall MI and may be caused by ischemia and infarction of AV node and due to increased vagal tone. The level of conduction block is usually located within the AV node. Therefore, QRS complex is narrow and the risk of progression to complete heart block is low. Atropine should be reserved for patients with hypotension or symptom, and temporary pacing is rarely required. Mobitz block is observed much less often than Mobitz block in acute MI. As opposed to the Mobitz block is frequently associated with anterior MI and infranodal region and wide QRS complex. Because Mobitz block can progress suddenly to complete heart block, temporary pacemaker is indicated. Although complete heart block may occur with either inferior or anterior MI, the implication differ markedly depending on the location of the infarct. With inferior MI, heart block can progress from first to third degree heart block. The level of block is usually within and above the level of AV node, and the escape rhythm is often stable and the effect is transient. Although temporary pacing is often indicated and permanent pacemaker is rarely required. With anterior MI, the complete heart block is usually the result of extensive infarction involving bundle branches. The escape rhythm is usually unstable and AV block is permanent. Mortality is extremely high and the permanent pacing is almost always required for survival. Regarding supraventricular arrhythmia, atrial fibrillation may occur in 15% of patients early after MI, but atrial flutter and paroxysmal supraventricular tachycardia are not commonly seen. Although atrial fibrillation is commonly transient, it is the marker for increased morbidity and mortality, probably because it is associated with other adverse risk predictors such as LV dysfunction and congestive heart failure. Management of supraventricular arrhythmia in the setting of acute MI is similar to the management in other settings. However, there should be lower threshold for cardioversion and ventricular rate should be more aggressively controlled. Because of their beneficial effect for acute MI, beta blocker are agent of choice for rate control. Diltiazem and verapamil are served as alternative for patients without significant heart failure and LV dysfunction, whereas digoxin should be reserved for patients with concomitant LV dysfunction. Of antiarrhythmic agent available, amiodarone is safest for patients with a recent MI because it has low risk of causing arrhythmia. So, summary of advances in the management of the STEMI. Performance of the pre-hospital ECG reduces the reperfusion time in STEMI. Fibrinolytic therapy reduces the mortality versus placebo if administered within 12 hours of symptoms, but is associated with the small risk of intracranial hemorrhage. Aspirin reduces the mortality to similar extent as fibrinolytic. Primary PCI is superior to fibrinolytic therapy for patients who can be treated within the 90 days of presentation in high volume center. Transfer to another facility for early non-emergent PCI should be considered following successful fibrinolytic therapy. The addition of clopidogrel to aspirin, antithrombin, and fibrinolytic therapy reduces recurrent MI and mortality. Prasugrel, ticagrelor are preferred alternative to clopidogrel to reduce stent thrombosis and recurrent ischemic event, but an increased risk of bleeding. Enoxaparin is superior to unfractionated weight heparin as an adjunct to fibrinolytic therapy, but is associated with slightly more bleeding. Radial artery access may decrease the bleeding. Complications should be considered when feasible. Non-culprit primary PCI is not indicated in patients with STEMI cardiogenic shock at the time of presentation. Beta blocker improves the long-term outcome following STEMI, but may increases the risk when given early to patients with or at high risk heart failure. AC inhibitor prevent the adverse remodeling after STEMI and reduces the death and heart failure. Aldosterone antagonism reduces the mortality in patients with LV dysfunction or heart failure following MI and should be used in caution in individuals with the renal failure. Thank you.